Imagine you're walking into a pharmacy. Your eyes are, burning. They feel gritty. So you grab a premium bottle of artificial tears off the shelf.
Right, because the box promises to replenish your eye's natural moisture.
Exactly. You buy it, you put it in, and you feel like a little bit of relief. But what you probably don't realize is that you didn't just buy medicine. You just bought a liquid all-you-can-eat buffet for microscopic mites that are currently living, multiplying, and feeding on your eyelashes.
Which is, it's a genuinely horrifying thought.
Right.
But it is a very real clinical possibility if you fundamentally misunderstand what your eyes actually need.
Well, welcome to today's deep dive. Our mission today is to completely tear down how you view a condition you've almost certainly experienced, but likely dismissed. We're talking about dry eyes.
Yeah, and we are pulling from clinical pharmacology and medical pathology data today to show you that this really isn't just a minor temporary annoyance. It's not just a symptom of, staring at a spreadsheet for too long.
No, far from it. When you look at the clinical data, dry eye disease is revealed to be a highly complex chronic medical condition. It's basically a cascading failure of the ocular surface with surprising triggers, hidden pharmacological traps, and incredibly specific treatments.
By the end of this deep dive, we're going to uncover why having eyes that won't stop watering might actually mean you're suffering from severe dryness.
Right. And we'll look at how common acne medications can permanently alter the anatomy of your eyelids. And of course, as I mentioned, we will break down exactly how buying the wrong over-the-counter eye drop could be fertilizing an ecosystem of microscopic parasites.
But to even begin to understand how those mites play into this, we really have to throw out the biggest assumption people make.
Which is?
The idea that a dry eye is just like a puddle of water that evaporated and simply needs to be topped up with a splash of liquid.
Right, the sponge metaphor. We think of our eyes like a dry sponge sitting on a kitchen counter. You run it under the tap, it absorbs the water, and boom, problem solved.
Exactly. It's a very comforting, binary way to look at the world. But the clinical definition we're examining today establishes some incredibly high stakes right out of the gate.
Yeah, because this affects up to 40% of the population.
Yeah.
And it's defined as a multifactorial disease of the ocular surface characterized by this is a quote, loss of homeostasis of the tear film.
And that phrase right there is the key to everything. Loss of homeostasis. It means a delicate biological system has lost its balance.
Right.
Your eye is a highly regulated microenvironment. When homeostasis breaks down, the pathology involves hyperosmolarity, neurosensory abnormalities, and actual physical damage to the cells on the surface of your eye.
Okay, I actually have to stop you there and push back on the clinical severity of this a little bit.
Sure.
Because the data notes that chronic inflammation is present in a third of cases, acting as both a cause and a consequence, and that it can actually impact long-term vision.
Right, it can.
But, if my eyes just feel a bit scratchy because the heater is on in my office, how does that leap to permanent vision damage? That feels like an exaggeration, to scare people into buying eye drops.
I get that. It sounds extreme, but the physiology totally backs it up.
Yeah.
Let's break down that term you just read, hyperosmolarity.
Okay.
When the volume or the quality of your tears drops, the water evaporates. But the salts dissolved in those tears, they do not evaporate.
Okay, so the tears remaining on your eye become way too concentrated.
Exactly. They become incredibly salty.
So it's kind of like having the Dead Sea sitting directly on your eyeball.
That is a perfect analogy, yeah. And human cells absolutely cannot tolerate being bathed in excessive salt.
Because of osmosis, right?
Exactly. Through simple osmosis, that salty environment pulls the water out of the delicate epithelial cells on the surface of your eye. Those cells shrivel, they become damaged, and they die.
Oh, wow.
And your immune system senses this cellular death and triggers an inflammatory cascade.
And inflammation brings heat, redness, and swelling?
Right. But here's the vicious cycle. As those surface cells are damaged by inflammation, they lose their ability to produce the proteins and mucins that, physically hold tears onto the eye.
Oh, I see. Which means the tears you do have fall off even faster.
Precisely. Leading to more saltiness, which leads to more cellular death, which leads to more inflammation. Over time, years of this chronic, simmering inflammation can actually scar the clear cornea.
Which is how it permanently impacts your vision.
Exactly. It is a progressive structural health problem, not just a passing feeling of tiredness.
That definitely reframes things. It's a progressive structural breakdown. And the clinical breakdown divides this disease into two main categories, right? Tear deficiency and accelerated evaporation.
Yes.
But here is the curveball in the data. Pure aqueous deficiency, literally just your lacrimal glands failing to produce enough liquid water, is actually quite rare.
It is. People assume they aren't making enough tears, but the reality is usually much more frustrating. We are making the tears. We're just losing them almost instantly.
Right, so the real crisis driving this 40% of the population is accelerated evaporation.
Exactly.
So if our bodies are pumping out the water, why is it vanishing into thin air?
Because of a failure in the protective seal. A healthy tear film is not just water. It's an incredibly sophisticated three-layer system.
Okay, break that down for us.
You have a mucus layer holding the water to the eye, the thick middle layer of water itself, and then floating right on top of that water is a microscopic lipid layer, an oil slick.
Like oil floating on top of a puddle in a parking lot.
Yes, and that oil layer has one vital job. It seals the water in and prevents it from evaporating into the air.
And where does that oil come from? Because it's not the tear glands, right?
No, it isn't. It's produced by tiny specialized glands called Meibomian glands, which line the inner edges of both your upper and lower eyelids.
So evaporation happens because of a deficiency in that oil layer. It's an oil problem, not a water problem.
Explain.
The clinical data links this Meibomian gland dysfunction to skin conditions like blepharitis, rosacea, and dermatitis, which makes sense because it's a sebaceous gland issue. But there's a medication link to this that absolutely stopped me in my tracks. Isotretinoin.
Ah, yes. The heavy-duty acne medication, most commonly recognized under the brand name Accutane.
Yes. The data states that this drug can cause an irreversible loss of these Meibomian glands. Think about the mechanism there. You take a pill in your teens or 20s to stop severe acne.
Right, and it works by shrinking the sebaceous glands in your skin so they stop producing the oil that clogs your pores.
But the drug is systemic. It travels everywhere in your bloodstream. It doesn't know the difference between a pimple-causing gland on your chin and a crucial tear-protecting Meibomian gland in your eyelid.
It doesn't, so it attacks the glands in your eyelids too.
And the clinical word used in the source is irreversible. You take this pill for your skin, and you could permanently kill the tiny oil factories in your eyelids that keep your tears from evaporating, basically for the rest of your life.
Yet once those specific glands atrophy and die, we have no medical way to bring them back. It is a permanent reduction in your eye's ability to retain moisture.
That's terrifying.
It is. But chemical destruction isn't the only way we lose this oil layer. We are also causing an evaporation crisis mechanically through something called the blinking deficit.
Right, because making the oil isn't enough. You have to physically spread it around.
Blinking is the mechanism. Every time you blink, your eyelid acts like a windshield wiper, pulling a fresh layer of that protective oil from the margins of your eyelids and smoothing it perfectly across the watery surface of your eye.
I want everyone listening to think about what they're doing right now. Because if you're staring at your phone, looking at a computer screen, or even intensely focused on driving, your brain is actively suppressing your blink reflex.
We become visually locked in on these glowing rectangles, and our blink rate drastically plummets.
And when you don't blink, that oil layer separates and degrades.
Right, and the water layer is suddenly exposed to the dry, climate-controlled air of your office or car, and it evaporates instantly.
The neurology behind this goes even deeper, actually. The data points out that Parkinson's disease plays a role here as a dysautonomic symptom.
Yeah, let's unpack the word dysautonomic. It refers to a dysfunction of the autonomic nervous system.
The background operating system of your body, basically.
Exactly. The system that controls things you don't have to think about, like heart rate, digestion, and automatic blink reflex. In Parkinson's, the signals that tell the eyelids to constantly sweep and refresh that oil layer get delayed or weakened.
So if the oil breaks down and the water evaporates, it leads to the most bizarre and contradictory symptom of this entire disease.
Oh, paradoxical hypertearing.
Yes, you get photophobia, which is extreme light sensitivity.
Yeah.
You get blurred vision and the physical feeling of a sharp grain of sand trapped under your lid. But then you also get this paradoxical hypertearing. I just don't understand how one of the primary symptoms of dry eye disease is having eyes that won't stop watering.
I know, it seems completely illogical until you put all the mechanical pieces together.
Walk us through it.
If your meibomian glands are blocked, or you've stared at a screen so long your oil layer has vanished, the water evaporates. Your eye physically dries out, and the sensory nerves embedded in your cornea panic.
So they sound the alarm.
They fire off a massive emergency signal to your lacrimal gland, basically screaming, "We are exposed! Flood the system!"
So the eye turns on the emergency fire hose.
It floods the surface with reflex tears. but reflex tears are almost entirely water.
Ah, and because you still don't have that oil layer to lock the new water in.
But because water has a high surface tension, it can't spread evenly over a dry surface. Think of pouring water onto a freshly waxed car hood. It just beads up and rolls off,
So the tears just cascade over your eyelids and stream down your face?
leaving the actual surface of the eye completely dry and burning just moments later. You are physically crying, tears are soaking your cheeks, yet your eye remains parched. It is a tragic biological misunderstanding. The body is trying desperately to save itself, but it's using the wrong tools.
That makes perfect sense of the paradox. And it leads directly into a crucial clinical rule highlighted in the data. The intensity of a patient's symptoms does not correlate with the severity of the disease or the risk of structural complications.
This is vital for anyone assessing their own health. You might have severe, vision-threatening cellular damage with only mild occasional irritation.
Because the nerves might be damaged.
Exactly. And conversely, you might have incredibly painful burning symptoms, but very little actual clinical damage to the cornea. The nerve endings on the eye are just highly variable. You simply cannot rely on how it feels to tell you how structurally compromised your eye is.
If we know that relying on pain is a bad metric, who should be actively looking out for this? Like, if estrogen drops during menopause and hormones regulate sebaceous glands, does that mean menopausal women are the most at risk?
Statistically, yes. The demographic data shows that the most frequent group for isolated idiopathic dry eye, meaning dry eye, with no other obvious external cause, is menopausal women.
Because of the hormonal shift?
Right, the hormonal shift directly downregulates the function of those Meibomian oil glands.
But systemic conditions play a massive role too. Diabetes, hepatitis C, vitamin A deficiency, and autoimmune diseases. It is fascinating to me that autoimmune conditions like Sjogren's syndrome, lupus, and rheumatoid arthritis are major culprits.
They absolutely are.
Up to 20% of rheumatoid arthritis patients suffer from dry eyes. It's like the eye is the canary in the coal mine. The immune system is attacking the joints, but it's also attacking the moisture-producing glands.
It perfectly demonstrates that the eye is not an isolated organ. It is deeply tied to systemic vascular and immune health. But, for many people, the real danger isn't an autoimmune disease. It's the hidden chemical traps sitting right inside their medicine cabinets.
Right. Let's talk about medication sabotage. Because the list of everyday drugs that systemically dry out the eyes is staggering. Diuretics for blood pressure, beta blockers, tricyclic antidepressants, and SSRIs.
Right, the incredibly common antidepressants taken by millions of people daily.
Exactly.
Take SSRIs or common allergy medications like antihistamines. We take an antihistamine to stop a runny nose and itchy eyes. The mechanism of that drug involves blocking histamine, which stops the allergic fluid response.
But many of these drugs also have anticholinergic properties.
Meaning they block the neurotransmitter acetylcholine.
Right. And acetylcholine is the messenger that tells your body's secretory glands to pump out moisture, right? Saliva in your mouth, mucus in your nose, and tears in your eyes.
Yeah, so when you take an antihistamine, you are systemically turning off the moisture faucets all over your body.
This sets up a terrifyingly common trap. You get seasonal allergies, so you take an antihistamine pill. That pill systemically dries out your mucosal membranes. Now your eyes are burning and irritated because the tear film has evaporated. So you go to the pharmacy to buy basic, cheap, over-the-counter eye drops to find relief. But the preservatives inside those very eye drops, specifically a chemical called benzalkonium chloride, or BA, actually cause dry eyes.
It is the perfect downward spiral. Benzalkonium chloride is a highly effective, incredibly aggressive preservative.
What does it actually do?
Its job is to violently break open the cell walls of bacteria inside the plastic bottle so the liquid can sit on a shelf for years without growing mold.
But I'm guessing it doesn't magically stop breaking open cell walls once it hits your eyeball?
No, it doesn't. When you drop BA into your eye, it is toxic to the delicate epithelial cells of the ocular surface. It actively strips away the lipid layer and accelerates cellular death.
So you are essentially putting a tiny drop of cell-destroying detergent into your eye every time you use it.
Pretty much. Which is why clinical protocols are incredibly strict about this. Any eye drop containing benzalkonium chloride should be used a maximum of 4 times a day.
Because otherwise the cells can't recover.
Exactly. If your eyes are dry enough that you need drops 5, 6, or 7 times a day, you are applying that detergent so frequently that your cells cannot regenerate. If you need it that often, or if you have moderate to severe dryness, you absolutely must use preservative-free formulas.
So if cheap preservative drops are essentially toxic soap, what are we actually supposed to use to stop the evaporation and break this inflammatory cycle?
Well, first we have to recognize that restoring homeostasis takes time. The clinical protocol makes it clear. Managing this disease takes several months of sustained effort. You need immediate symptom relief combined with long-term mechanical management.
The non-pharmacological treatments depend entirely on identifying your specific mechanism of failure.
Right.
Like if your issue is a lack of oil because of clogged Meibomian glands, you use warm compresses to literally melt the hardened, buttery oil stuck in the gland so it can flow again.
But if your primary issue is acute inflammation and burning, a warm compress will actually make it worse. You need cold compresses to constrict the blood vessels and calm the immune response.
It also requires environmental management, right? Keeping your home and office at 40 to 50% humidity, taking high-quality omega-3 supplements to biologically improve the fluidity of the oil your glands produce.
And doing conscious blinking exercises.
Which blew my mind. The prescribed metric is 5 minutes of active, conscious blinking for every hour of screen time. You physically have to retrain your nervous system to sweep that oil across the eye.
It's tedious, but necessary. But when lifestyle changes aren't enough, we move to the pharmacological gold standard, sodium hyaluronate.
Strictly without preservatives, sodium hyaluronate is a powerful viscosifying agent.
Right.
Let's unpack that term for a second. What does a viscosifying agent physically do on the eye?
On a molecular level, it acts like a microscopic, highly absorbent sponge. It binds to water molecules and holds them tightly against the surface of the eye, preventing them from evaporating into the air.
So it thickens the tears.
It thickens the tear film without blurring your vision. And it actually has natural anti-inflammatory properties that help those damaged epithelial cells heal and regenerate.
The clinical data highlights specific brand treats here, pointing out Hytrilo and Hydrosense as premium examples because they deliver hyaluronic completely preservative-free. But what fascinated me is the engineering required to pull that off.
It's pretty incredible.
Because Hytrilo is sterile for 6 months after opening, and Hydrosense is good for 12 months. Normally, without preservatives, bacteria from the air would contaminate the bottle immediately.
They achieve this sterility using complex anti-reflux valve built directly into the nozzle.
Instead of a normal bottle that dispenses a drop and then sucks air back in to replace the lost volume, which pulls airborne bacteria right into the liquid, these bottles use a spring-loaded silver wire mechanism.
Yes.
You push down, the valve opens to release exactly one drop, and it instantly snaps shut, creating a physical, airtight barrier. No air, and therefore no bacteria, can ever flow backward into the reservoir.
It is brilliant medical engineering. But it creates an entirely new clinical dilemma.
The accessibility issue. The pressure required to operate that heavy-duty mechanical valve is significant. The medical data explicitly flags that a patient with severe rheumatoid arthritis who, as we discussed earlier, is at a massive 20% risk for dry eye, might literally lack the finger strength to squeeze the bottle.
It perfectly illustrates why treatment must be holistic. You can prescribe the absolute best, scientifically perfect hyaluronate drop on the market. But if the patient physically cannot dispense it due to joint degeneration, the treatment fails.
And that nuance extends to how we manage the disease around the clock. The protocol relies on different formats for different times of day. You use low-viscosity liquid drops during the day so your vision stays sharp.
But at night, when you don't need to see, you switch to heavy gels or thick ointments.
Night ointments provide the longest action. They utilize ingredients like mineral oil or white petrolatum. They don't just add moisture, they coat the entire ocular surface in a thick physical barrier that prevents any evaporation while you sleep.
Though patients should be aware that some ointments use lanolin, derived from sheep's wool, which can trigger an allergic reaction in sensitive individuals.
Definitely something to watch out for. And to clear up a massive myth about storing all these products, keeping your drops in the refrigerator does absolutely nothing to extend their chemical shelf life. A standard bottle of drops lasts 4 weeks once opened. Ointments last 1 to 3 months.
Sticking them in the fridge might make the liquid feel nice and soothing on a burning eye, but the expiration dates are strictly about bacterial sterility, not thermal preservation. Once that seal is broken, the clock is ticking.
While the daily regimen of drops and ointments can manage the majority of cases, the clinical documents contain severe red flags indicating when self-treatment needs to stop immediately. Like, if there is no improvement after 72 hours of trying basic treatments, you are outside the realm of simple dryness.
Absolutely. Other critical warning signs that require an optometrist or ophthalmologist include altered vision that doesn't clear when you blink, extreme sensitivity to light, deep, throbbing eye pain, rather than just surface scratching, abnormal pupil size, or pronounced angry redness.
Speaking of redness, there is a hard, explicit warning in the data against using decongestant drops. Products like Visine or Clear Eyes. People use them before a meeting or a photo to make their eyes look white.
Oh, they do. And they work by using chemicals that forcefully constrict the blood vessels in the sclera, the white part of your eye. They temporarily mask the redness by choking off the blood supply.
Which sounds terrible.
It is. They are highly irritating, heavily preserved, and once the chemical wears off, the blood vessels rebound and dilate even larger than before. You are actively worsening the underlying inflammatory pathology just for cosmetic vanity.
But the biggest warning, the one that brings us back to the horrifying scenario from the beginning of this deep dive, is the danger of advanced lipid drops.
Right, the formulation's designed to replace the oil layer.
Products like Sustain Balance or Refresh Optivevans say use triglycerides, mineral oil, or castor oil to artificially recreate that lipid seal. The data states unequivocally that these drops require a medical recommendation, because if you guess wrong about your pathology, you might feed a parasite. Let's talk about Demodex.
Demodex is a microscopic mite. It is naturally occurring and lives on the human body, specifically inside hair follicles and the sebaceous glands at the base of our eyelashes. In small numbers, they are part of our normal biome.
But when their population explodes on your ocular surface, they cause severe inflammation, basically plugging up those Meibomian glands with their waste.
And here is the critical physiological detail. Demodex mites survive by eating lipids. Their entire diet is oil.
Okay, so if your dry eye disease is actually being driven by an overpopulation of these mites burrowing into your eyelids, and you go to the pharmacy and buy an advanced lipid drop to soothe the irritation.
You are literally pouring a highly engineered, nutrient-rich oil slick directly onto the parasite colony. You are fertilizing the infestation and guaranteeing the inflammation will get worse.
It is the ultimate proof that you cannot guess your way through this disease. Dry eye is not a one-size-fits-all condition. If your problem is a lack of water, a lack of oil, a toxic medication, or an army of mites, the wrong treatment doesn't just fail. It actively accelerates the damage.
Exactly. Only a professional looking at your eye under a high-powered slit lamp microscope can tell you exactly which mechanism has broken down.
It really demands a complete paradigm shift in how we view ocular health. We have to respect the biological complexity of the tear film.
We really do.
So as we wrap up this deep dive, the biggest takeaway for you listening is to elevate your respect for your own biology. Dry eye is a chronic, progressive inflammatory disease. It's not a passing mood. You need to consciously blink when you're lost in a glowing screen. You need to avoid the toxic trap of benzalkonium chloride and cheap artificial tears, and you absolutely must get a real clinical diagnosis before you start dumping premium oils or parasite food onto your eyes.
And, recognizing that complexity brings up a final fascinating question about our evolutionary trajectory.
What do you mean?
Well, look at the modern world we've built for ourselves. We spend our lives staring unblinking at backlit screens. We breathe artificially dry, climate-controlled air. We consume a daily cocktail of systemic medications that turn off our mucous membranes.
All right.
Our entire modern lifestyle is fundamentally incompatible with the delicate homeostasis of the human tear film. It forces us to ask, are we rapidly approaching an evolutionary turning point where applying complex prescriptive artificial tears will no longer be considered a medical treatment for a disease, but rather a universal, non-negotiable daily routine, as fundamental and necessary as brushing our teeth?
Wow, that is a staggering thought. Eye care transitioning from medicine to just standard daily hygiene for the digital age. It certainly shatters the simple sponge metaphor we started with.
Right.
Because you are not a dry sponge sitting on a counter waiting for a splash of water. You are a complex, delicate, and deeply interconnected biological ecosystem. Treat it wisely. Thanks for joining us on this deep dive. We'll catch you next time.